Hi class, Dr. Jim here. Chapter 19. Chapter 19 looks at the gram-positive bacillus. And so we're going to spend the whole discussion today looking at the gram-positive. So each one of these will stain dark purple with the gram stain, except I should make this exception, the Mycobacterium, which we're going to look at. So that's the one for Mycobacterium tuberculosis, which is the one that causes tuberculosis. And then they also the leprae, which causes leprosy. And so we'll look at that near the end of this discussion today, but all these other guys are going to stain positive. They're also going to look rod shaped, and they tend to be pretty large rod shaped. Now we're going to look at types that are both aerobic and anaerobic. We're going to look at types that form spores versus some that don't form spores. And if you remember back to chapter 11 and 12, spores are the really tough things to kill. And so that's what makes some of these things really tough. And it kind of makes an explanation of why you have to be careful when you do some of these crazy injury things, like especially when you get a puncture wound or you step on a nail, why you need a tetanus shot and all these other things. And so in this chapter, chapter 19, we're going to look at the gram-positive. And then in chapter 20, which is the next lecture, we're going to be looking at the gram-negative bacilli, which includes things like E. coli and some of these other wonderful intestinal parasites. Well, they're not really intestinal, but they are intestinal, but they're not really parasites. So we'll look at all these different things and see how all these things can cause disease and what they do and how they do all these different things. So let's begin today. All right, so if we look at our objectives, the first thing we're going to look at is what are the important gram-positive spore-forming bacillus bacteria. So this chapter is really broken down into three major groups. You have the spore formers, the ones that form endospores, the non-spore formers, and then the ones that are irregular shaped or have some different cell walls than normal. And so that's how we really divide this chapter. So we'll spend probably a third of the time talking about the spore formers, which includes Bacillus and Clostridium. The next one third, or maybe even less than that, just the non-spore formers, which we primarily look at just Listeria in that case, and then finally some of the different bacteria that are in there, including the Mycobacterium. We also talk about the diphtheria, the Corynebacterium, and things like this, or Corynebacterium, and looking at some of these different groups. And so again, we're going to be talking about all these different things. Keep in mind gram-positive and rod shape when we look at these things. And again, what are the important gram-positive non-spore forming, and then finally the gram-positive irregular shape. So that's kind of how we're going to go. We'll start with spore formers, non-spore formers, and then the irregular shaped or weak gram-positive staining. Okay, so kind of think of that as we go along. All right, so again, we can divide into three groups. We talked about this already, the endospore formers, the non-endospore formers, and then the irregularly shaped or staining properties. And again, that goes with the Mycobacterium. So we'll take a look at that. Again, this just divides it up, shows you the different groups we're going to be looking at. So for, again, like I said, about the third of the time, or pretty close to half the time, we're going to be looking at the spore formers, which include Bacillus, and then Clostridium has a very large number of different organisms that cause disease, including Perfringes, which causes gas gangrene. You have tetani, which causes tetanus. You have Botulinum that causes botulism. And then finally, the other one that's relatively new that can cause severe diarrhea. And a lot of you guys that are in the medical field going into nursing and that are probably aware of Clostridium difficile, or better known as C. diff. And so that's a wonderful diarrhea one that's involved with superinfection, so long-term antibiotics and that. And again, we'll talk about that as we go through these things. We'll then look at the regular shape and staining properties, and again, we'll spend our time with Listeria because that's an important one. This is one of the reasons why your doctor says don't eat lunch meat if you're pregnant, and that's because of the threat of Listeria. You also have to be careful of dairy a lot of times with those things because Listeria does grow really well at cold temperatures. And then finally, we'll look at a couple of these guys, including the Corynebacterium, the Corynebacterium. It's one tough one to pronounce. It's a non-acid fast, but this one is responsible for diphtheria. So we'll look at the diphtheria and the diphtheria toxin. We'll then spend some time talking about Mycobacterium. The one I really want you to know is tuberculosis, because we do see that quite a bit in the hospitals now, especially if you're immune compromised. And we see it a lot of times in immigrants that come to this country as well that are coming from areas that are endemic. And then finally, we'll spend one slide on the actinomyces and nocardia. that's looking at these ones. And again, these are interesting ones, and the reason why I bring these up is because we're seeing it a lot of times in military personnel that get wounds over in Afghanistan or Iraq that are coming back and getting these types of infections in their wounds, and they're very difficult to treat. So that's why I bring that up right now. I don't have a lot of information on that, and you definitely can find out more about that, especially if you're going to go work in the VA or somewhere like that where you're dealing with military personnel. You might see more of that as opposed to someone more domestic, or in this country getting an infection. It's not as common here, but we do definitely see it in military personnel that do get treated overseas and then come back home and then have this infection. So we'll look at that as well as we go on throughout this lecture. All right, so the first two we're going to talk about are the spore formers. And so remember, they make endospores. Those endospores are really tough to kill. And so you have to think about that. That's storing your DNA in kind of like a time capsule that can come out again at any time when the conditions are right. The two groups we're going to look at is Bacillus and then Clostridium. Now, the interesting thing that separates these two out, they're both rod-shaped bacteria. They both form spores, but the difference is Bacillus is aerobic, meaning they grow aerobically, they need oxygen, where Clostridium is one that is anaerobic. You need anaerobic conditions. And so one way we can treat people with Clostridium infections is putting oxygen in there, because oxygen kills. And so that's one of the techniques, or one of the therapies for people that have gas gangrene in that, and we'll look at that as well. So that's a major distinction between the Bacillus and the Clostridium. Aerobic, anaerobic. Okay, so remember that. Both are spore formers, but one is aerobic, the other one is anaerobic. Okay, so let's look at Bacillus first, and then we'll get into Clostridium. So again, Bacillus is a gram-positive endospore-forming motile rod, so it has flagella, can move. Most of the time, they grow on dead, decaying things. They're aerobic and catalase positive, so they'll bubble with hydrogen peroxide. And again, they're versatile and degrading complex macromolecules. So you find these a lot of times in soil. Think of soil bacteria. And again, they're a good source of antibiotics. Again, their habitat is soil. And the two species that you probably have heard of, or maybe you've only heard of one, is Bacillus anthracis, which is the anthrax, and the other one is Bacillus cereus, or B cereus. You should always be serious in micro. That's my little micro joke. And this, again, is another soil-forming one that we see that can cause a lot of times GI problems, or sometimes some foodborne illness. So the other one is anthrax, and obviously you may have heard of stuff about anthrax, maybe if you were around here in 2001 or were growing up in 2001, and you heard about the scare of spores in the mail and that stuff. The senators and that in Washington, D.C. were getting weaponized grade anthrax being sent to them, and that was the spores. You breathe that in and you can get really, really sick from that. So we'll look at that as well as we go along. Okay, so Bacillus anthracis, again, are large block-shaped rods, and they have central spores that develop under all conditions except in the living body. Okay, so these things develop very well. And again, the virulence factors include a polypeptide capsule and exotoxins. And so what really gets people sick is the exotoxins these things release, because they damage the nerves and they cause a cardiac and respiratory failure when they're found in the lungs. And so we'll explain that in just a minute. These are what they look like. So they look like these very long rods, but these are all actually multiple bacilli all growing together. So you can see they form these very long chains. And again, a lot of times you can see the spores in the middle. So they tend to form this spore right in the middle of the body. Okay. Now, there are three types of anthrax that are out there. The most common type is actually cutaneous, is because it's a soil bacteria. And so when you have wounds on your hands, so if you're like a gardener or a farmer that's working the field and you have cuts and sores on your hand, you are likely to get this, but it's not common, type of thing. It is one of those things that it is found primarily in the soil, and these spores can get into your wounds and leave this mark. And so you can tell that it's a sign of this cutaneous anthrax because you get this dark or black sore, which is called an eschar. This eschar is a large sore that forms, that is basically necrotic tissue forming from the anthrax, releasing toxins and killing the skin. Again, it's the least dangerous form of all because it's very superficial, doesn't get very deep into tissues. So again, it's very treatable with antibiotics. So it's not one of those things that you could die from. However, it's pretty nasty and can be very disfiguring if you're talking about these very large black lesions that form on your skin. Okay. The second type, and probably the most scary type, is the pulmonary. And the pulmonary one is when you actually breathe the endospores in. This is what was happening in 2001, and we're actually killing people because they'd open their mail, and as you open the mail, that dust would come in, you'd breathe in those spores, and those spores would vegetate into bacteria cells in your lungs. Once they get into your lungs, they grow into the bacteria, they start releasing the toxin, and that toxin can lead to respiratory failure. And that's what was killing people, was the respiratory failure due to the toxin. And then the third type is gastrointestinal. And the gastrointestinal is actually when you eat things that are contaminated by the spores. And that typically is a case of diarrhea, nausea, vomiting for a couple of days, and then it goes away and you don't really know. And it's probably more of, oh, I just ate something that didn't agree with me and, didn't like that. And so it could be just one of these things that's a temporary issue. Like I said, the pulmonary one is the worst of all three. This is the one that could actually lead to serious consequences, and you could die from that type of interaction with the bacteria, with the toxin in that as well. So that's a serious one. The problem with pulmonary is a lot of times once you start to see symptoms, it's too late to treat, and that's the scary thing. So you have to almost know that you're breathing in those spores to go get treatment before the vegetative bacteria start releasing that toxin, because once the toxin is starting to be made, you start feeling the symptoms. They're really the prognosis for living through that infection are pretty grim. Okay, so that's the bad thing about that as well. So we'll continue on and talk a little bit more about anthrax here. Now, again, it's controlled and treated with penicillin, tetracycline, or the drug that most people were getting when they were getting the inhalation one was ciprofloxacin. And again, cipro is another type of drug. That was that one that's stored in the CDC vault and that stuff. So a lot of times they worry about anthrax being one because it is so easily to be sporulated and weaponized, as they call it, because you can release these spores into air systems and get lots of people sick. So that's why Cipro is one of those we want to keep on lockbox type of thing to have for first responders, because that will probably be one of those that people would try to use as a biological weapon. There are vaccines available for this, for anthrax. However, most of the time they're used as a way to prevent livestock from getting sick. And so there is that's used by a lot of farmers because, again, this is found in the soil, can end up in the feed and that stuff. And so that's where where animals are likely to get it. Now, there is a purified toxoid vaccine that's given for high risk occupations. So again, you're going to be the front line in the military, you might get this or some other things. And so this was one of those that people think that, if you remember back to, this is even earlier than 2001, 1992, if you remember Desert Storm and people were getting this desert storm like flu, a lot of people were suspecting that it might be this anthrax vaccine that they were getting that was actually making them sick. There is some possibility. I don't remember, I don't recall the data on all that, so you can't take my word for it, but there was some speculation that it was the vaccine. I haven't heard much since then about the vaccine, so I'm assuming that it's relatively safe and that it isn't anything. So if you guys are thinking about getting into the military or the reserves or something like that, and they do suggest that you get this vaccine, I think it is relatively safe. I haven't heard any new data or anything else about it, but it may be out there, it may not be. It just depends on the risk of a biological weapon and that stuff. So just want you to be aware if you do end up going that route and you go and serve in the military for that, you may see that vaccine there. But for most people, we do not get vaccinated for anthrax, again, because the risk of it, the level, the only time we'd probably see it would be as a biological weapon. And so again, we do have antibiotics for it. So vaccination is probably not the biggest thing right now for people. But if it did get to be a concern, it might be another option down the road. Okay, now another one that causes some foodborne illnesses is the Bacillus cereus. And this is, again, found in airborne, dustborne, and in, again, usual methods of disinfection and antisepsis are ineffective because of the endospores. The endospores fly in the dust and that stuff and land on things. A lot of times grows in foods. They survive cooking and reheating. And again, what happens is you get this toxin containing food, causes nausea, vomiting, abdominal cramps, and diarrhea for a 24-hour duration. Typically, this is your 24-hour flu, one of the types of 24-hour flu that are out there. Again, there's no treatment. Typically, you just let it go, you let it pass. Obviously, if it continues on more than 24 to 48 hours and you get severely dehydrated, that's when you want to take steps. That's when you probably want to go to the ER or to the doctor to make sure that you're okay and that you don't get too dehydrated in that case. We do see an increase in, again, immunosuppressed. So those that are on immunotherapy for treatment are, again, immunotherapy for cancers and tissue transplants and things like this. Also with AIDS patients and that we do see this. But again, this typically happens most of the time, not a big deal. You have to suffer through the symptoms for a 24-hour duration and then it goes away. And that's typically what we see with the be serious. And you should always be serious. That's, I like that one. Be serious about microbiology, or be serious about be serious. Okay. All right. So now let's move on to Clostridium. This is the other spore former that I really want to spend a little bit of time on. There are really 4 different strains that we're going to concentrate on today. The first one causes gas gangrene. The second one causes tetanus. The third one causes food poisoning and botulism. And the fourth one is the C. diff, which is the one that causes diarrhea. So we'll look at all 4 of these things. Now, what makes this one different than the bacillus is that these are anaerobic. So these don't want oxygen present. So where are you going to see these? In very deep puncture wounds that oxygen isn't getting to. So it has to get under the skin into deep tissues where there's no oxygen present so that it can grow and thrive. If you have oxygen present, these guys won't grow. And so a lot of times you need puncture or stabbing type wounds, gunshot wounds, things like this. That's where you're going to see it. Again, they're oval to spherical spores produced only under anaerobic conditions. They synthesize organic acids, alcohols, and exotoxins. And again, we find them in wound infections, tissue infections, and food intoxication. So we'll look at all these different things. And like I said, there's 4 main ones that we're going to look at today. Okay, the first one is the Clostridium perfringens. This is the most frequent Clostridia involved in soft tissue, and it leads to a myonecrosis or muscle necrosis. So it eats away at the muscle and the carbohydrates that are involved in the muscle. Okay, the spores are found in soil, human skin, intestine, and the vagina. And again, the predisposing factors are surgical incisions, compound fractures, diabetic ulcers, septic abortions, puncture wounds, and gunshot wounds. So really it is getting past that first mechanical barrier. So the spores have to get into you in order to cause damage. If they can't get into you, there's going to be oxygen around. It's going to kill these things. The spores aren't going to be able to come out. So there's probably lots of these things around. Most of the time we don't have any problems because we're not puncturing ourselves and doing all these things. But when we're talking about surgical incisions, we're talking about puncture wounds, crushing injuries, things like this, you have to get these spores into deep, dark tissue where there's no oxygen. If that happens, that's where these guys thrive, and then they can cause disease. Here's a picture of what these spores look like, and you can see the spores tend to grow at the end of the bacillus, but I'm sorry, not the bacillus, of the rod. But again, you can see these things, and again, these are anaerobic bacteria. Okay. Again, it releases this alpha toxin, which leads to blood cell rupture, edema, and tissue destruction. It has collagenase, which breaks down connective tissue, hyaluronidase, which is also connective tissue, and DNase to destroy DNA. Here's an interesting picture, again, looking at a microscopic lesion. You can see here's the bacteria. The bacteria is actually creating air spaces around the muscle fibers. You can see inside the muscle fibers because it's breaking down the muscle. It's feeding off the carbohydrates that are in the muscle because you got lots of carbs to make sure your mitochondria are working really well. And those feed, and what they do is release gas. Every time they eat, the bacteria eat, they release more and more gas. That fills up the space, the empty space, with gas, and you kind of get the gas part of the gas gangrene. The other part is the green part, or the diseased or dying tissue, which is a kind of a greenish from the heme being released from the blood, and the deep dark black that is turning from the necrosis. So you see a little bit of all these things happening when the tissue starts breaking down. Okay, and so that's what you assume with this. So you start to see these really nasty, deep, dark wounds forming with gas gangrene. Okay, it's not highly invasive and requires damaged and dead tissue for anaerobic conditions. Again, you have to get these things in deep tissue and they have to get in really deep where there's no oxygen present. So it's not something that you're just going to pick up from a skin cut or something like this. It's going to be a real crushing type of injury that allows for a lot of these spores to get in, and then the skin really closing up on itself so that it causes the oxygen not to be into that area. If oxygen's there, the spores are not going to hatch, and so that's the biggest thing. Again, conditions stimulate spore germination, vegetative growth, and release of exotoxins, other virulence factors that start eating away at the tissue. That's producing the gas part of it. Also, then you have dying disease tissue, which starts breaking away. And again, you start to see the formation of gas due to fermentation of the muscle carbohydrates. Here you can see someone's leg that has the gas gangrene. So again, here's the tissue. You can start to see these pockets of these gas, or basically the bubbling of the gas that's coming to the surface of the skin. You also see the dark areas, which is the gangrene part, which is growing. And again, we see this very typically associated with deep puncture wounds and things, gunshot wounds, knife stabbings, things like this, where you're going to get the puncture wound and then it's going to close up to keep those bacteria nice and anaerobic. So that's where you're going to see these things. Okay. Again, treatment and prevention. Again, cleaning of dirty wounds is very important. Deep wounds, compound fractures, and infected incisions are all important to actually clean and really take care of those wounds. And so if you do that, you're going to be at a very low risk of getting this. Again, also debridement of diseased tissue is very important, because once they start going necrotic, you got to remove the necrotic tissue because there's nothing to feed on. If you have clean, healthy tissue, the bacteria is not going to have anything to feed on. The other thing is you're going to get on large doses of antibiotics. And then again, one of the big things that they'll do is actually open up the wound and keep it engorged with oxygen, because the oxygen will kill the bacteria. So that, along with the antibiotics, should work really well. So that's why they put people in hyperbaric chambers when they do have suspected gas gangrene, to help kill those infections. There's no vaccine for it. And again, typically you're not going to see it unless it's associated with these deep puncture wounds. Sometimes you see it with frostbite, because again, you got necrotic tissue deep in the tissue and it's dead. And so the bacteria have something to feed off of, and so that's where you're going to see these types of things: crushing injuries, frostbite, puncture wounds, anything very deep and no oxygen present. Okay. So, which of the following is a mode of transmission for B. cereus? Is it through inhalation, ingestion, entry through wounds, or sexual contact? So, B. cereus was the foodborne illness. What one would you think this one would cause? And I should really move the slide to the other spot. So this doesn't make a whole lot of sense, but maybe it does. So, which one do you think it is? If it's foodborne, it would be ingestion. If you got ingestion, good job. If you didn't, again, you might want to go back and look at, but B. cereus is the one that causes the 24-hour flu-like symptoms: nausea, vomiting, diarrhea, and then it goes away, the 24-hour flu. So if you get that ever, one of the guys that might cause this is B. cereus or Bacillus cereus. Okay, next one, Clostridium tetani. Clostridium tetani is one that causes tetanus. Okay, and so again, it's just like the gas gangrene that are the peripharynges that causes gas gangrene. Tetani is one that, again, is probably more common that you hear about, because we always think about getting a tetanus shot. Okay, and so it's a very common resident of the soil and GI tracts of animals, and so that's why we worry about this so much, because it's pretty much found everywhere in that. And so anything that's outside could potentially have those spores. And so tetani can cause tetanus, or lockjaw it's called, and it is a neuromuscular disease. So what it does, it actually goes in and affects the nerves. And then again, most commonly among geriatric patients and IV drug abusers. We also see it in neonates with the stumps. Sometimes you'll see it in frostbite, but a lot of times we associate it with either cuts when we're outside and we cut ourselves with something metal, or get a puncture wound, kind of like if we step on a nail or something sharp that's kind of rusty, because there's that potential for spores to be there, and those spores get in and cause disease. And so that's what we see. So yeah, that's kind of what we look at and see those spores and that. And so that's why it's very common, and that's why if something does happen outside and it's been a while since you've had a tetanus shot the last time, you're just safer just to go get one and just do it. It takes about 20 minutes to do, and just get a shot, and then that way you're protected and you don't have to worry about getting this disease. Okay, so that's kind of why we think about this. All right, so what is the pathology of this? So what happens is again, spores typically are all over. Think of anything on the ground or anything on metal around the outside. And these things enter through an accidental puncture, wound, burns, umbilical stumps, frostbite, or crushed body parts. And again, the spores get in just like gas gangrene. And especially if you step on something or cut yourself with something, the spores can get into the bloodstream. Okay, and then they travel and work their way to the spine, and they get into the cerebral spinal fluid, and then they grow and release this toxin. And so once they get into the spine, that's where they can do their damage and wreak their havoc, because what happens, they release the toxin, and the toxin binds to the nerves, and that's where it causes the problem. Okay, and so what you get is called this tetanospasm. That is the toxin, and it causes paralysis by binding to the motor nerve endings. And so what happens is that it basically blocks the inhibitory response of the neuro pathways. Okay, and so typically you have two pathways. You have the ones that turn muscles on and ones that inhibit and turn muscles off, so that you release your muscle contraction. Okay, and so what this toxin does is it basically binds to the inhibitory receptor, so you don't get any inhibition of shutting down the muscles. So it causes this constant contraction and tightening of the muscles. And so the problem is that this can lead to a lot of areas where you get these spasms where it just constricts and it doesn't release. Okay, which you might say, well, that's not such a bad thing. I can see the lockjaw locking your jaw into place and that stuff, and you could survive. However, the problem is that you have one large muscle down here called the diaphragm. And if that diaphragm becomes constricted and can't move anymore, you're not breathing. And so that can be a very serious consequence. And so that's what happens with a lot of these people, where you get respiratory muscles that cannot move, and that's where the death comes from. So you get collapse of the respiratory system. So this can lead to death if untreated. But again, this would be in areas where they don't have any medical care. You may be out somewhere in the middle of nowhere and you get this and you haven't had a tetanus shot in a while. But if you've been vaccinated in the last 10 years, you should be protected from this bacteria. So that's a good thing. So that's why we always say make sure you have your tetanus shot every 7 to 10 years, and you should be fine, even if you step on a nail. Okay, so here's one of neonatal tetanus, and this is typically through the umbilical stump. What happens is the bacteria or the spores get in that way. If it was left open, somehow it got into the stump, and then it can cause this complete contraction of the muscle, okay, of the muscles in the baby. You can see the flexing and the tenseness of the child here in that case. Okay, now how do we treat it? Well, it's aimed at deterring the degree of toxemia. So again, once the bacteria is in you, it starts releasing that toxin. So what we'd like to do is give you an antitoxin therapy to block the toxin to prevent the inhibition and the contraction part. Again, it inactivates the circulating toxin, but it doesn't do anything that's already bound. So that's the problem. So then what you have to do is you have to wait until it becomes unbound. And so you have to control the infection with penicillin, tetracycline, and then part of the therapy is giving muscle relaxants, so that it will calm down the muscles, and so it will relax and eventually work again. Again, there's a booster shot every 10 years. It's recommended. And anytime you cut yourself or do anything, you're always better just to get a tetanus shot. And I was dumb enough last year. I had some garden shears and I cut my hand trimming some bushes and that stuff. And I immediately knew, oh, I'm the microbiologist. Even though I knew I had a tetanus shot a while back, I was like, well, I'm probably safer just going to get one and being safe than just letting it go and then worrying about, am I going to get tetanus or not? Maybe you don't think about that, but as a microbiologist, I do. So I went and got it. It was better, got it in a day. Not a big deal. 20 minutes, got the shot. Of course, you have a sore arm for about 3 days or 2 days, and then you get over it and it'll be fine. But again, it's just the peace of mind to have that, and you're protected, and there's no problems with it. Okay. Now, the third type is the Clostridium difficile, or C. diff. And so again, some of you may be aware of this, especially if you've been working in hospitals or nursing homes where people get this. Again, typically this is a resident in the colon. And again, colon, you think of the large intestine, not a lot of oxygen in there. And so, but you only see it in low numbers. And the reason for the low numbers is for all the high numbers of E. coli and all the other enteric species that you have in your colon. So that typically keeps these numbers really low. Where we see this a lot of times, where people get this, is that if they have some kind of immune dysfunction or they're on long-term antibiotics. That's primarily where we see patients that end up developing this. They go on long-term antibiotics, roughly 6 months to a year. If you've been on antibiotics that long, you're more than likely going to get this. What happens is you just wipe out all your normal flora, and that allows for the C. diff, which isn't touched by the antibiotics, to grow and flourish. And so a lot of times this is what we term as that super infection. So if you remember from chapter 12, and we talked about antibiotics and the super infection, this is the guy that causes a lot of these super infections. So this is where we see it. The problem is when one person gets it, it's easily passively transmitted from one person to another. So if you see this in a nursing home, this can easily spread from patient to patient, because again, you're already talking about people that are immunocompromised or elderly, and these things can easily spread. So if you have someone that has a lot of it, and they have an accident diarrhea, you clean it up and you forget to wash everything or change your gloves, and then you go and treat someone right away in an emergency situation, you could spread that disease potentially to them. Okay. Produces enterotoxins that damage the intestines. Again, it's a major cause of diarrhea in hospitals. And again, it's becoming common in community-acquired diarrhea. So we're seeing it more and more and more. And that's because people are on long-term antibiotics longer, things like these super infections develop. And when we see these grow out, you see them start to be passed from one person to another. So it's not the best thing. But a lot of times it starts when that person's on long-term antibiotics, starts as a super infection, and then can spread from there. Okay. Now, here's a picture of a healthy colon. I want to show you a healthy colon versus one that has the C. diff. And again, you can kind of see that it's becoming ulcerated. Again, a lot of times in these situations, you get mild or uncomplicated cases where fluid and dehydration are the biggest thing. If you get this serious diarrhea, the biggest thing you can do is rehydrate your patients and that stuff. So that's going to be the number one thing, rehydration and making sure that their fluids are normal. If you have severe infections where it's not going away, they will put you on some stronger antibiotics to try and get rid of the C. diff. But again, it's like you're treating people with a lot of times antibiotics already, and now you have to come back and hit them with even stronger antibiotics and that stuff. And again, sometimes they will do this thing it's essentially called a poop or fecal replacement, where they basically take fecal material from one person and replace it into someone's intestine. So they either go through the nose with the tube and down and enter and put in the new fecal material into the intestine, or they go the other way up. So kind of like an increased colonoscopy type of thing. So you pick your poison, I guess, in that one. But if you have this case, I guess you'd settle for anything just to feel better and that stuff. And again, the biggest thing is passage in the hospitals. When one patient gets it, you want to make sure that you're not passing to other patients. So again, spreading the disease is really important to prevent. And so preventative measures and that is a big thing. So if one person gets it, you're not spreading it to the rest of the hospital. So that's the other thing as well. But we're seeing it more and more. So just be aware of those things and make sure you take care of it as it goes along. Okay. Some other types of food poisoning, and again, we're going to spend a few minutes on botulinum. Botulinum is the one that causes botulism, and so this one is a more not prevention, but more likely to cause severe disease in this case. Whereas the perfringes is one of more of a mild food intoxication. And it's again the second most common form of food poisoning worldwide. And again, that's just ingestion of spores on food. You eat it, you get food poisoning, you get some gastrointestinal distress. A lot of times we see it with vegetables and that, homegrown vegetables and that grown in soil. And typically you see this occasional, and you get over it real quick and not a big deal. The one you don't get over real quick is the botulinum, and we'll talk about that here in just a second. Okay, so botulism is again intoxication associated with inadequate food preservation. And again, where we see this a lot of times are people that like to can their own food. And I'll talk about this in a second. So, canning the home jars and that stuff. So you want to make sure if you or if you're one of those people that do home canning, that you do good, basically good cleaning, good degermination and that stuff, so that you do it the correct way, so that you don't potentially set something up so that you can get this foodborne poison or botulism from doing it. So Clostridium botulinum is a spore-forming anaerobe commonly found in soil and water, again outside, associated with the ground. and that in cooking and that. So again, preserving with vegetables and that stuff from a home garden, very common. Now, spores are present in food when gathered and processed. And again, if a reliable temperature and pressure are not achieved, the air will be evacuated to create an anaerobic environment, but the spores will remain. So it's important that you do proper home canning. If you don't get the proper pressure and temperature, you're setting yourself up for this type of thing to occur. Anaerobic conditions favor spore germination and vegetative growth. And again, the botulinum toxin, which is also known as Botox, is released. And so you guys have heard of Botox before. This is the same toxin that can cause botulism, but it's also used for many other things, including injection into the body for releasing wrinkles and things like this. And so we'll talk about that here in just a minute. But it is the same toxin. Okay, just want you to be aware of that thing. Okay. What the botulinum toxin does is it goes to the neuromuscular junctions. It prevents acetylcholine from being released between the neuromuscular junction. So essentially what happens is that you get no response through the nerves. The nerves can't respond and you get a flaccid paralysis that occurs with this. And so typically you start to see the normal foodborne problems, but then what you get with it, so you get nausea, vomiting, diarrhea, but then you also will see double or blurred vision associated with this, difficulty swallowing, and then neuromuscular symptoms, weakening of the muscles, maybe paralysis, and other things associated with this. And this is very common in people that don't prepare their canned food properly. And so that's where we see these things occur. Okay. Now, another, like I said, the botulinum is the Botox, and this is again used to treat a lot of different things. Again, like wrinkles, it can be used for chronic underarm sweating, cervical dystonia, which is again causes severe neck and shoulder muscle contractions, the blepharospasm, which is uncontrollable blinking, strabismus, which is misaligned eyes, chronic migraine, overactive bladder, lots of different treatments because you want to paralyze these different things. So think of anything you want to paralyze. That's the type of reaction. And so I like to show, here's Wayne Newton, Mr. I've got enough Botox in my face to be plastic almost. And you see this a lot of times because what it does is it paralyzes the muscles so they can't contract, and so you don't see wrinkles, and so it gives you a smooth appearance, but then you can't move your face at all. So again, you might have a nice smooth appearance, but you look like you're a complete plastic face because you can't move or show any emotions. And again, typically the Botox, the injections have to be repeated, and it lasts anywhere from about 3 to 12 months. So again, we do see lots of good things with it, but it can be overused sometimes in the cosmetics therapy realm. So I want you to remember Botox can be used for cosmetic therapy, but there's also a lot of other therapies that. All right, so we also see infant botulism, which is ingested spores that germinate and release toxin. Again, flaccid paralysis, and then sometimes you can even get wound botulism where the spores enter through deep wounds and can cause food poisoning symptoms. So that's kind of a different one that you might not think about, but that can occur too. And again, it's all about the release of spores. Now, treatment and prevention, again, determine the presence of toxin in food, intestinal contents, and feces. So you look for the bacteria in these cases and these things. Again, there is an antitoxin to block the botulinum toxin. Cardiac and respiratory support, again, if it starts shutting down the cardiac muscle or the respiratory muscles. Again, infectious botulism is treated with penicillin or a derivative of that. And again, the biggest thing is practicing safe canning methods. So preserving and handling of canned foods, addition of preservatives and things like this will help because again it prevents the spores from becoming activated and growing in the anaerobic environment. So that's your biggest thing. Okay, so being safe, doing home canning, that's the biggest thing. All right, and then again, Clostridium perfringens, which causes gas gangrene, can also cause gastroenteritis, and again, it contaminates food, and again, it's not cooked enough to destroy the spores. The spores germinate and multiply, especially unrefrigerated, and then you consume. The toxin is in the intestine, causes the epithelial cells to release. You get cramping and diarrhea, nausea, sometimes vomiting. And again, it's a pretty rapid recovery in about a day or two of having these episodes of diarrhea and vomiting, and then eventually it goes away, and then you feel better and you don't think anything of the worst. And so you accumulate it to something that, hey, maybe I ate something, and that's what it was. So again, that's how it can go sometimes. All right, so that's what we see with the Clostridium perfringens. All right, so again, we looked at all these different spore formers. The two bacillus, again, remember these are aerobes, and again, the B. cereus is a facultative anaerobe, and again, but we typically associate bacillus with the aerobes, and again, these form spores, and they're involved typically either in anthrax or food poisoning. Then we have the four different types of Clostridium, and again, Clostridium perfringens, the gas gangrene or food poisoning. The C. diff or Clostridium difficile. Again, we see it with colitis or diarrhea, the tetani with tetanus, and the botulinum with the botulism. And so that's where you see these different types of things. And again, you may see motility, you may not, but one thing you see in all of these things are those wonderful endospores, tough to kill. Okay, and so that's the biggest thing. All right, so the action of the botulin toxin is on the what? Spinal nerve, cerebellum, neuromuscular junction, or smooth muscle. Which one do you think it is? Okay, if you said the neuromuscular junction, you would be correct because again, what it does is prevents the acetylcholine from being released, causes a flaccid paralysis in your muscles. So the acetylcholine is necessary to cross that synapses. And so when it crosses synapses, it triggers the muscle to contract. In this case, you don't have the acetylcholine. So again, now you have paralysis, the muscle can't move, and that's how this toxin works, by blocking the acetylcholine. So good job if you got it right. All right, so now let's take a few minutes looking at the non-spore-forming bacilli. And the only one that I want you to look at is Listeria. So we'll keep it short and simple on this one, and then we'll get into some of these other ones here at the end. Okay, so Listeria is an important one because Listeria is associated with foodborne illness, and we'll talk a little bit about it. Now, typically, most people are fine getting this. If you get a foodborne illness, doesn't cause much of an issue, maybe cause a little discomfort, some nausea, vomiting, diarrhea. However, where it can be a problem is if you're pregnant and you get this bacteria, because it can cross the placenta and cause serious complications with the fetus and lead to death of the fetus as well. So this is one of the reasons why we talk about this. Okay, now again, they're non-spore-forming gram-positive bacteria. They range from coccobacilli to long filaments, and typically they have 1 to 4 flagella. They do not have capsules. The biggest thing is they're resistant to cold. They actually flourish pretty well in cold, heat, salt, pH extremes, and bile, so they do very well in a lot of different environments. And again, the virulence is attributed to the ability to replicate in the cytoplasm of cells. So what they do is they actually trick the macrophages to making them say, hey, eat me. So these guys get eaten, and then they get into the cell, the macrophage, where they can actually break out of the lysosome and then replicate inside these cells. And then they can break off and go into other parts of the body, or they can be transported in the macrophage to anywhere that they want to go. And so they use the macrophage for their bidding to transport them around the body. And this is how they avoid the immune system, because now they're inside immune cells. So it's pretty crazy about these guys and how they can cause disease. Okay, so what is the epidemiology and pathology? So the epidemiology is, again, they are primarily found in soil and water and in animal intestines. So where do these get associated? Think of slaughterhouses, where you're going to have animal intestines and where you're going to have this stuff a lot of times. And so if you ever want to watch where your food comes from, watch Food Inc. That's a really good documentary about where our food all comes from, and you get to see slaughterhouses in general and see how that all works. And you see basically where they slice the cow open and the intestines just fall right onto the floor and that stuff. And so this is where we see this stuff associated. Again, what happens is when you have these intestines and these things that get into that, you have where they can contaminate food. Okay, they grow during refrigeration and grow in the cold type of thing. Okay, and so they grow really well in the refrigerator. And then the listeriosis in most cases are associated with either dairy products, poultry, or meat. And again, they get into the meat and cause problems, and they often are mild or subclinical in most people. Again, you may get some diarrhea or vomiting or other things, and so it can cause some issues there. Okay, and then typically it goes away and you don't think of it anymore. Now, where it causes the most problems are in the immune-compromised patients, the fetuses, the neonates, and can affect the brain and meninges, and that can be up to a 20% death rate if these people are left untreated. So again, if you let this go and you cause this problem, this is where you see this death rate. Now again, for the raw foods, it can cause again during pregnancy, the raw foods itself can cause problems, and so that's where we see these issues where it causes these problems. You eat these raw foods or processed meat products. So again, the deli fresh and that stuff a lot of times are associated with Listeria outbreaks. You see these things, you eat them, and they can cause serious problems. And so that's why your doctors will tell you don't eat meat or don't eat the lunch meat if you're pregnant, because again, that bacteria can cross the placenta and cause disease. And so that's where we see those actually happening. All right, so diagnosis and control. The culture requires a lengthy cold enrichment process. So again, growing in the cold. So that's why these things grow really well when we're talking about in the cold refrigerated environment. So again, they get into your lunch meat, they grow in the cold, and then they can get you sick. Now there are rapid diagnostic tests, including the ELISA, immunofluorescence, and DNA analysis to detect and see if you have this pathogen. And again, treatment is ampicillin or the what is it? The trimethoprim sulfamethiazole in that. And again, that is the sulfa drugs if we think about that. And again, the best thing for it is pasteurization and cooking. So drinking pasteurized beverages and then cooking your lunch meat to a certain temperature to kill the bacteria. So they do withstand some heat, but again, if you heat it up to the proper temperature, then you don't have problems where this can cause issues. Okay, so that's where we see this. So that's the prevention part. All right, so now the last part that we're going to talk about are some of these non-spore forming and irregularly shaped bacilli and also irregular staining. So the two main ones we're going to talk about here are the Corynebacteria and then the Mycobacterium. The Corynebacterium is the one that causes diphtheria, and the Mycobacterium is the one that leads to tuberculosis. Some of these other ones, the Propionibacterium bacteria, the Propionibacterium is the one that causes acne, and then the actinomyces and nocardia are ones that we typically are seeing in wound infections and things like this. We're seeing more of, and so I'll briefly mention those at the end. But the two I want you to think about are the Corynebacterium and then the Mycobacterium. Okay. Now the Corynebacterium diphtheriae is a gram-positive irregular bacilli, so it's kind of irregularly shaped. It's a little bent and that stuff, and so that's why they call it the irregular bacilli. And that looks like this, very gram-positive. In that case, no spores in this situation, but again, typically you'll see it as palisades sometimes or as granules and other types of shapes. So that's where you see it. Okay, the epidemiology is again found in healthy carriers. So, and what we find is that little kids are the ones that are getting this. And so, if you've ever seen the commercial, I always like to refer to commercials when you see this. So, if you've seen the commercial where grandma is the wolf and the baby comes over, the little Red Riding Hood baby comes over, and she has the cough, that is the healthy carrier spreading it to the baby. So, that's one of those things. So, a lot of times these are spread by healthy people that don't even know they have it, that spread it to the unvaccinated or the ones that are immunocompromised. And so the potential for this is always present because there are the healthy carriers. Again, most cases occur in non-immunized children and living in crowded, unsanitary conditions because, again, easy spread through respiratory droplets and from carriers in actively infected individuals. So that's where we see this a lot of times. Okay, again, the two stages of disease. The first one is a local infection that you find in the back of the throat. And again, it's an upper respiratory inflammation. So you get a sore throat, nausea, vomiting, swollen lymph nodes. The biggest thing that can form, if you look over here, is the pseudomembrane. So you kind of see this growth. And what that does is it actually grows over the back of the throat. It can potentially cause asphyxiation because you can't get oxygen back there because it basically clogs up or covers up the back of the throat. So it covers up the pharynx. And so now no oxygen from the mouth or the nose can actually get in. So you can die from asphyxiation from this. The other thing that this guy releases is called the diphtherotoxin, which when it produces this toxin can release toxemia and target organs, especially the heart and nerves, and cause damage there. And so that's the second stage or the systemic stage of this disease. Okay, so the diagnostic methods is looking for the pseudomembrane and the swelling. So if you start to see this membrane growing around the back of the throat, that's indicative of diphtheria. Also, if you do the stains, you can kind of see they kind of look almost like turkey legs or sometimes these barbell shaped. And so that's another thing that you notice with diphtheria because it's irregularly shaped bacillus. The conditions and history of which these children are at. So if they haven't been vaccinated for diphtheria, that is one way. And then serological assays that we do have looking at antibodies and antigens and seeing if they react to the antibodies. So these antibody tests. Now, again, typically where we see this is people that have not or chose not to be vaccinated. And so that's where you see it. And again, healthy carriers can spread this to people. And so that's where you see that all the time. And that's where you want to be careful with these things. And so that's, again, it can spread from one person to another through healthy carriers and if they're not vaccinated. And so diphtheria is part of the DTaP, which is diphtheria, tetanus, and pertussis. And so those are the three vaccines you get in one. So a lot of times you'll get what is called the DTaP if you're going for your tetanus shot. You also will get vaccinated for diphtheria and pertussis. And so those are the common things. And again, these are required every 10 years or so. And so if you know that you had a tetanus shot in the last 10 years, you probably had the DTaP and you need another tetanus shot, you can just go for tetanus and that, or you can get tetanus and pertussis. It just depends. But typically it's found as a trivalent vaccine. So that's typically where we see it. Okay, there is an antitoxin for when people do get this disease and they need to block the pertussis toxin. It can be treated with penicillin or erythromycin, and there is the toxoid vaccine, like I said, the DTaP, the diphtheria, tetanus, and pertussis toxin that you can take. And so that is one, again, administered about every 10 years as boosters or doses of that. And so that's where you see those things. Okay, another one is the Propionibacteria, and that is again the acnes bacteria, the most common type of acne. Again, these are gram-positive rods. They tend to be aerotolerant or anaerobic. They're non-toxigenic, and again, a common resident of the phyllosebaceous glands. And so we see this a lot of times in the face. Again, healthy pore, one that gets clogged, and then you get the swollen one with the pus, and that it leads to acne. And again, I've told you before when we looked at the Staph aureus with the staph infections that you shouldn't be picking your pimples. And the reason why is because once you get blood involved, that bacteria can get into the blood and it can go to places that you don't want it to go to. So that's why I recommend not picking your pimples and doing all those things. I know it's kind of gross, but I know you guys go out there do that. So you don't want to be doing those types of things because it can lead to more serious types of infections. Okay. All right, so a disease that causes a pseudomembrane and a respiratory distress can be prevented with a vaccine. Is that true or false? So what are we talking about here? We're talking about the disease diphtheria, and is there a vaccine for diphtheria? You said true, you'd be correct. So I already said the DTaP vaccine, diphtheria, tetanus, and pertussis. The diphtheria is part of that trivalent vaccine, and that would be true. Good job. All right, so the next group of bacteria we're going to be talking about are the mycobacteria. And the mycobacteria include tuberculosis and leprosy. There are a couple other ones I just want you to be aware of. We'll talk about it at the end. But the Mycobacterium tuberculosis is the one that we're going to spend a few minutes on here in just a few minutes. Now, again, the gram-positive irregular bacilli, the biggest thing with these is that they typically don't stain well with the gram stain, and that's because they have mycolic acid in their cell walls. They have unique acid, the mycolic acid. That's where the myco comes from, the mycolic lipids. And these mycolic acids in the cell wall cause it not to stain very well with the gram stain, but very well with the acid-fast stain. So that's the type of thing that we see. The one interesting thing about the mycobacteria is they grow very slowly. So these are very slow, very lethargic kind of bacteria when we think of growth. You know, we talked about growth before and E. coli growing every 20 minutes to a half hour. These guys take 3 weeks to multiply. So these are very slow growing. So very, very slow. If you got this as an unknown, you would be hating me for days because this thing would just not grow and you'd just be like, Dr. Jim, are you just toying with me or what's going on here? And so the mycobacterium are these really slow growing, slow invasive infections. And so very difficult to catch, but once you catch it, it's very difficult to get rid of. And so that's the idea. So it's hard to get, but once you get it, it's very hard to get rid of in that sense. Okay. Now here are a number of species of Mycobacterium. Again, the two that we're going to talk about mostly today are the tuberculosis and the, let's see if I can find the other one in here, leprae at the bottom. Okay, and so these are the two that we'll talk about. There are a few other ones that can cause disease. This one is the bovis, which can cause tuberculosis that we see in cattle, and again can be spread to humans. Not always, but can. The other one that we see a lot of times is the mammarium, and this is an interesting one because people will get what is called the swimming pool granuloma. And I'll show you a picture of this in a few minutes. But this is one where if you go in swimming and you go into the pool and you scrape your arm or you scrape your hand, it can cause this kind of fleshy wound to occur, and I'll show you what that looks like. And that can cause kind of a wound abscess in that in there, and it can be treated, but again, it's caused by this Mycobacterium mammarium, and so we'll see this. Okay, so we'll take a look at some of these again as we go along. Okay, so again, the Mycobacterium tuberculosis is called the tubercle bacillus because again, it's found to grow the tubercles in the lungs. Again, produces no exotoxins or enzymes that contribute, so it has very little in the way of I can't think of it, virulence factors. Okay, so very little in the virulence factors, but it does have some factors on the outside that help keep it from being attacked by the immune system, including complex waxes and the cord factors that keep it from being eaten up by the macrophages and the lysosomes. Okay. So what is the epidemiology of tuberculosis? Well, again, predisposing factors include inadequate nutrition, debilitation of the immune system, poor access to medical care, lung damage, and genetics. And again, typically we don't see many naturalized citizens get TB unless they're with someone that has it. Where we're seeing a lot of the infections are one in the immunocompromised people that have HIV or AIDS, and the other place we're seeing a lot of is in immigrants that come from areas that are endemic. And so they had the infection at one time in their lifetime, and they came over here, and then it reactivates later on. And so that's where we're seeing again about 1/3 of the population in 15 million United States actually carry the disease. And again, the highest rate is occurring in the recent immigrants that are coming to the United States. And again, it's very resistant and it's transmitted through airborne respiratory droplets. So it can be infectious. The problem is that it doesn't grow very well. So it's not something that you're going to catch just by walking in accidentally into a room that someone has TB. Where you're going to get it is that if you're constantly being a healthcare provider for someone that has it and you're right next to them and you're breathing that air, and that slowly inoculates you over time. And so that's where you're going to get the TB from. Okay, again, about 5 to 10 million people, 10% of infected people develop a clinical disease. So it is, again, those that actually get it actually develop disease, and it's only about 5 to 10% that actually get it that develop any disease. And again, left untreated, progresses very slowly, and it remains contained in the lungs. Okay. Again, clinical tuberculosis can be divided into three actually stages. You have the primary, which is the initial infection of TB. That will either go away or get walled off by the body. You can have a reactivation of the disease later in life, which is called secondary tuberculosis if it stays in the lungs. And then you have disseminated, which means it leaves the lungs. And that's obviously the most serious case. Once it leaves the lungs, that's where the life outcome can be very dire, because once you get it disseminated throughout the body, it can wreak havoc and cause a lot of destruction to tissues and organs and that. And so once you get to that stage, it's very difficult not only to treat, but actually survive the disease. And so what we'll be primarily looking at is the primary and the secondary types of tuberculosis. Now, again, the infectious dose is only 10 cells, so you don't need a lot to get sick. So that's why it's easy to catch, in the sense that, just breathing in 10 cells is not impossible if you get someone that's coughing up, tuberculosis bacteria. However, it's one of those things that it has to get in, and then it has to establish, and then it's a slow growing infection, so it takes a long time. Okay, so again, what happens is the bacteria gets phagocytosed by these alveolar macrophages in the lungs. After 3 or 4 weeks, the immune system attacks, forming these tubercles or granulomas consisting of a central core. So you see all these lymphocytes surrounding the bacteria, and it starts to wall these things off. And this is what they're looking for in a lung x-ray. So when they do a chest x-ray, what they're looking for are these spots. And these spots represent an actively growing type of tuberculosis, so the TB. If they start to see these tubercles or these granulomas forming, that's a sign that says, you've got activated TB. Now, if one of these center tubercles break, it can cause necrotic caseous lesions, which gradually heal by calcification, and that also leads to these white scars that you'll see in the lungs as well. and that's another sign of TB. Okay, so again, typically with the secondary TB, it only occurs if you don't treat it the first time. So if you have the primary TB, let it run its course, and you get better, you can always develop secondary TB if you don't get treated with antibiotics. So what happens is the bacteria are kind of walled off for a while, and eventually they figure out a way and break out. And if they stay in the lungs, you get it reactivated, and that is called secondary TB once it's in the lungs. Typically, there's more severe symptoms involved with this, where you have violent coughing, greenish or bloody sputum, fever, anorexia, weight loss, and again, left untreated can lead to a 60% mortality rate. Now, sometimes this secondary can actually break out of the lungs, get into the bloodstream, and go to other parts of the body. And if that's the case, then you're talking about very severe extrapulmonary tuberculosis, which is, again, that disseminated. And so during secondary TB, these guys can leave and go into the lymph nodes, kidneys, long bones, genital tract, brain, and meninges. And when this happens, especially if it goes to the brain and meninges, you don't have a very high risk of surviving. The mortality rate is about 90 to 95% in these cases, and it's probably going to be very difficult to treat and get rid of. And so again, it's all about being preventative. Obviously, knowing where you are and taking care of. If you're taking care of someone that has it, always wear a mask so that you don't have any chance of breathing in these particles. If you do end up taking these particles, making sure that you check to see, regularly if you're TB positive. Again, what happens is you guys go in, get the TB shot, and then if you're positive for there, they make you go get a chest x-ray, and I'll explain why that is in a minute. But keeping up with those things, those testing and things like that, will always keep you safe so that you know. Okay, now how do we diagnose? Well, the first thing they do is they inject antibody or antigen underneath the skin, and this is that wonderful wheel or arthros reaction. And so you're looking for development of an antigen antibody reaction. And again, this is called the Monod test. And what it does is it looks like a mosquito bite. This is a very positive test. And again, category 3 means that they were probably either exposed to TB or had an activated form of the disease. And that's why they say, okay, if you have a positive of this, you're going to get a chest x-ray. So that's the second part. They look for the tubercles. If your chest x-ray comes out clear, you're passed, you're fine, you go on with your daily life. But if you have these tubercles or these cloudiness in your lungs, what they will do then is then put you on IV antibiotics or long-term antibiotics to kill the bacteria, because this represents either that you had an activated case or you have an active case at the moment. And so that is one of those things. Now, one of the problems with these tests, so the Monod test and the chest x-ray, is some of you guys may be from other countries, and you may have been vaccinated for TB, because TB is endemic in areas. And so if you've been vaccinated for TB, you may actually have a positive test because you already have the antigen antibodies inside of you that would cause this response to occur. So if you do a Monod test, it's going to give you a big response because you've been vaccinated. And so if you've been vaccinated for TB sometime in your life, you will have a positive test. But the nice thing is if you go get your chest x-ray, it'll be nice and clear, because that will obviously. Now, some places have now gone to a blood test and looking for it actually in the blood, and that's a safer test. It's less likely to throw false positives in that, and so that's more becoming more of nature. And so I know some of the hospitals around the Milwaukee area are offering blood testing as opposed to that skin test to avoid the false positives and that stuff. And so that's one of those things. Okay, so again, sometimes that doesn't mean you have TB if it does happen, because sometimes getting enough injections under your skin will also cause a false positive. And again, the chest x-ray is the definitive thing. If you don't have any tubercles in there, you're fine, you're clear. But if they start to see these white patches like these in here, that signifies that you had an activated form or an active form of the disease. You will then go off and then onto antibiotic therapy for a while. Okay, and then again, direct identification of the sputum and biochemical testing are always done once they determine they have tubercles, to see if it's an active form or if it is a deactivated form that could result in secondary. So that's what they look for as well. Okay, so management and prevention. If you are diagnosed with TB, you go on a 6 to 24 month of antibiotics and at least 2 drugs from the list of 11. Again, there is a one-pill regimen called Rivaftor, and Rivaftor is one of those that has 3 antibiotics combined, and so that's why it's a one-pill regimen. And so you may see this if you're treated for TB. Again, there is a vaccine used from attenuated strain of the M. bovis, and so this is found in other countries. And so some of you that have come from other countries may have been vaccinated already. And so this is something you want to tell your healthcare provider if you're going to work in the hospital, that you say that, hey, I've been vaccinated for TB, and I'm sure it will be on your vaccination record, because that will throw a false positive on the skin test. So right away, I'll tell you, you'll have a false positive, and then they will check through a chest x-ray to see if you have it or not. So I'm just putting that out there for you guys that may have been vaccinated before during your time, okay, during your lifetime. Okay, so how is tuberculosis spread? Is it spread through contaminated fomites, food, respiratory droplets, or vectors? What is the best way to spread TB? If you said respiratory droplets, you are correct, because remember, it's a lung disease, coughing up. The coughing up of the respiratory droplets are what spread it. Other people breathe that in, and then they can become inoculated with just the 10 bacteria that they need. So again, difficult to catch, but once you do catch it, very difficult to get rid of, okay, just because it's such a slow grower. All right, now the other disease that I'm going to talk about real quick is leprosy, and this is also another type of mycobacterium. Again, it's a strict parasite, hasn't been able to be grown outside of human artificial media or tissue culture. And again, it's the slowest growing of all species. So you think TB is bad, this takes even longer. This can be up to a month or 2 to actually multiply. It does multiply in host cells in large packets called globi, and again, it can cause leprosy, which is a chronic disease that begins in the skin and the mucous membranes and then gets into the deeper tissues and nerves over time. Okay. Again, it's found endemic in regions of the world. You may have heard about the leper colony out in Molokai, which was in Hawaii. So a lot what the countries were doing were sending their lepers to and basically an isolated little island and letting them live there. You can actually go visit these colonies. There's no one there anymore, but you can actually visit them now if you take a trip to Hawaii and go to the island of Molokai and see that. But right now, there's no lepers on there. And again, this is not one of those diseases that's very prevalent anymore, but you do see it in endemic parts of the world, okay? It's not fully verified of how it's spread, but I would say it's probably one of those things that it's skin-to-skin type of contact, because it is affecting the skin, the superficial skin, and it's probably passed that way from skin-to-skin contact from one person to another. And again, it's not highly virulent in that health and living conditions do influence the susceptibility of the disease, and it may be associated with specific genetic markers and that are out there. Okay, the macrophages will phagocytize the bacilli, but the weakened macrophages is slow T cell response may not kill it. And again, incubation is anywhere from 2 to 5 years. So this is a long-term disease. And again, if it's untreated, the bacilli grow slowly, and the skin macrophages and the Schwann cells of the underneath the skin and the skin tissues of the peripheral nerves will get infected with these things. And again, there's 2 types, the tuberculoid and the lepromatous. And again, these are the 2 different types of diseases that are associated with leprosy. Okay. The tuberculoid is an asymmetrical, shallow lesions, damages nerves, and local loss of pain reception. Again, you can see it here. Here's one of them. Here's another one. So you kind of get the name leprosy because of the leprosy spots that you see. And again, the skin damaging spots, these lesions on the skin. And so you see this. And so those that are remember stories of the Bible and that stuff will hear about this, the lepromatous, or the lepers of the different countries in the Middle East and that, and then in those stories in the Bible. So that's where they get the name, the lepers, and that. Okay, the lepromatous are ones that actually cause these deep nodules, infections that causes severe disfigurement. So you may see this associated with it. This is associated with leprosy, so much deeper. Also, again, you see the damaging to the superficial tissues, widespread dissemination throughout the body. Again, a lot of areas that are affected in these situations, and this is where you find it endemic in these areas. And again, deep tissue and a lot of other things. So think of skin disfigurement leading to nerve dysfunction in these different types of diseases. Okay, How do we diagnose? Well, it's a combination of symptomology, microscopic examination of the lesions and the patient history, where they've been. Again, numbness in hands and feet, loss of heat and cold sensitivity, muscle weakness, thickened earlobes, and chronic stuffy nose are all associated with this. And again, it's a nerve damaging disease. Again, detection of acid-fast bacilli and skin lesions, nasal discharges, and skin tissue samples are all part of the diagnosis and that stuff. Again, relatively rare, but we still do see areas of the world where endemic. And so any of you guys that are from those areas, or maybe you may be traveling to those areas, just want to be aware of those things. And again, one of those that's very difficult to catch because it is so slow growing. And again, we don't even understand how people really get it. I think it's more of a skin-to-skin contact. So more than likely, you're never going to hear or see this disease in any of your time, but I like to bring it up because it is published so much in different areas that you may have heard of it before. Okay, treatment and prevention. Again, treatment by long-term combined therapy. Prevention requires a constant surveillance of high-risk populations. And again, there are some trial vaccines, but again, nothing has come out where we say, yeah, we've conquered it or anything else. And so there is still trials and that stuff. And like I said, there are still areas in the world that are endemic with this disease. So you do see this quite a bit in other areas of the world. Okay. Now, again, I talked about some of these other ones. The Mycobacterium avium is now the third most common death in AIDS patients, and this is actually carried by birds. And so people that have pet birds are at risk of actually getting the disease, and that stuff is found in the respiratory tracts and digestive tracts of birds. It can be spread that way. But typically, we only see it in immunocompromised, typically, where people get this. Another one is the Kansai, which is, again, another one that causes pulmonary infections in adult white males with emphysema or bronchitis. Like I said, the mammarium, I'll show you a picture here in just a second, is a water inhabitant that lesions develop after scraping along a swimming pool. The sacrophyllicium infects cervical lymph nodes, and the paratuberculosis is found in raw cow's milk, and again, found in 65% of individuals diagnosed with Crohn's disease. And again, this is one of those things that we think may be triggering Crohn's disease, but it's not a cause and effect type of thing. Some of you guys that live in Wisconsin may be aware of raw milk, and what that is basically unpasteurized milk. And so you may see this in the unpasteurized milk, and this is what might get people sick. If you don't pasteurize, you're exposing yourself to more of the bacteria that's found in the milk taken from the udder of the cow, and whatever the cow has been exposed to could potentially pass on to you. And so unpasteurized could lead to these different types of things, and this is one of those that could be passed to you. Okay, here is the little mammarium one, and so this is the chronic swimming pool granuloma, and you can see this infection, again, typically caused by scraping your fingers or hands against the swimming pool bottom and causing you to have an ulcer form on there. And so that's kind of the swimming pool ulcer that people get. Again, can be treated with antibiotics, but it is a slow growing in this case. Not as slow as the tuberculosis in that, but can cause these very nasty, disfiguring little ulcers on the hands and feet, depending on where you scrape your body on those swimming pools. Okay, so one other thing to worry about out there. All right, the last slide, and I promise we're almost done, is the actinomyces and nocardia. These are the non-motile filamentous bacteria related to the Mycobacterium and may cause chronic skin infection in the skin and soft tissues. Now, the reason why I bring this up is because we're seeing more and more of these infections now in people that have gone, military people that have gone to Iraq and Afghanistan are coming back with wound injuries and now getting these infections. These infections are difficult to treat because they don't respond well to antibiotics, and they tend to be very nasty at eating the tissue and getting, causing a lot of problems. And so we see these things and causing very difficult wound infections to heal and treat in that, and causing disfiguring problems with these types of infections. And so that's the reason why I bring this up real quickly. Again, there are some antibiotics that work, and again, if you're going to work in a VA hospital, you may potentially see this in military personnel. Not common here in the United States, but those that serve in other parts of the world or work in other parts of the world and come back with tissue injuries, you may see this infection spring up more and more and more as time goes on. Okay, so that should be the last of the bacteria that we're going to be talking about today. All right, so when we talk about the concept check, which of the following is not caused by an acid-fast organism? Is it tuberculosis, Listeriosis, tuberculosis, or tuberculoid leprosy, tuberculosis, the swimming pool granuloma, or lepromanius leprosy. Which one is not caused by an acid-fast microorganism? Okay, if you remember Listeria is caused by Listeria monocytogenes, which is again a gram-positive, but is not an acid-fast. And so that was the one before that causes the foodborne illness that you have to worry about lunch meat with. So listeriosis is the answer. If you got that right, good job. You're paying attention and it's making some sense. If you didn't, it's okay because there's a lot of different bugs that we've been talking about, and again, just kind of keeping track. And again, I'm not going to be asking for really specifics on anything else when we take these tests. What I want you to know is just the three main groups: the spore formers, the non-spore formers, and then the irregular ones, either irregularly shaped or irregular staining in that case. And so that's what we're looking at today. All right, so let's move on to the summary. So again, we talked about the spore-forming gram-positive bacillus, and again, you can separate these to the two groups: aerobic versus anaerobic. That's the big key. So I might have a question on there: what separates the bacillus from the Clostridium? And that is aerobic versus anaerobic. Okay, and again, the Bacillus anthracis and the B. cereus. Anthracis causes anthrax. There's the three types: the cutaneous, the pulmonary, and then the digestive or gastrointestinal. The B. cereus is a cause of food poisoning, typically just a very quick 24-hour duration you get rid of. Then you have the anaerobic bacilli spore formers, and those are the Clostridium. The perfringes is a gas gangrene and also some food poisoning. The tetani leads to tetanus. This is the neurotoxin that causes the spasms and contractions. The lockjaw, remember that, blocks the inhibitory response. Botulinum is a neurotoxin that causes flaccid paralysis, so it prevents acetylcholine to going into the muscle, the neuromuscular junction, so you get flaccid paralysis. And then the C. difficile or C. diff is the one that causes the superinfections in the intestine. So we're seeing more of this as a chronic diarrhea. Now, the non-spore-forming gram-positive bacillus is the Listeria monocytogenes. Again, Listeria is the foodborne. This is the cold-loving bacteria found in dairy and raw meat. This is why your doctors say if you're pregnant, don't eat the raw meat and that stuff because of risk of these things. And again, it doesn't do much to the mom, but can cause serious complications to the fetus or the baby. And so that's why we don't like to see moms doing this to themselves. Don't eat the raw things. Either cook it or don't eat it altogether. And so give it up for a couple months until you have the baby, and then you can go back to eating your lunch meats and everything else. And again, where we see the highest risks are the immune compromised in the neonates. And again, one of the few psychrophile pathogenic bacteria that we work with because they are cold loving, they grow very well in the refrigerator, as opposed to most other mesophiles that don't grow very well. They're just kind of restricted at cold temperatures, where these guys will actually grow and flourish in cold temperatures. Okay, finally, the irregular shaped or staining gram or irregular staining gram-positive bacillus, and we talked about the Corynebacterium diphtheriae, the ones that cause diphtheria. You have the oropharynx infection, again, that causes that pseudomembrane to form, can die from asphyxiation. And then again, it's on the rise because already healthy carriers and non-vaccinated. So if you choose not to get vaccinated, you can get this disease. So go get vaccinated for this. Another one we talked about real quickly is the Propionibacterium acnes, which causes acne. The Mycobacterium tuberculosis, which is the main cause of TB. Again, we talked about the primary, which is again the first lung infection that occurs, goes away. You can develop the secondary or the pulmonary, which is basically the secondary is where it redevelops, it breaks out, and then the disseminated is the one where it breaks out of the lungs and can cause serious problems. Again, to test, you guys have probably, if you've gone in the medical care or medical field, you've had the skin test done, and then if that came out positive, you had the chest x-ray. And again, and then clinical isolation. It's a very slow grower, so it's not one that's easily spread. But again, if you're in constant contact with that person, the respiratory droplets, you are at risk of getting it. So being smart about that is always an issue. The Mycobacterium leprae causes leprosy. Again, it's the slowest of all the Mycobacterium in the growers, and again, could be a couple months for it to develop and that stuff. And again, spreading, not really sure, but I would guess that it would be like skin-to-skin contact or very close contact with someone that's infected with it. And again, one of those things we don't see very often, but there are areas of the world that are endemic for it, and you do see it still. And then the actinomyces and nocardia, these are skin and soft tissue diseases. And again, the reason why I bring this up is that, again, if you work with people in the military or yourself were in the military, you maybe have been exposed or been at risk to this with the wounds that you got for serving, and this may have caused an infection and that stuff that was very difficult to treat. So again, you may see this, especially if you go work in VA hospitals around the country. Okay, so we've made it to the end. I'm glad you guys are still keeping up and that stuff. If you have any questions, please email me. Please leave comments. Stop by my office, ask questions and do all those different things. If you need anything, please let me know. Happy you're watching. If you have any questions, please let me know. And I'll see you next time. Thanks for watching.